Speaking with Senior Advisor Moses Kuria, the Council of Economic Advisors for Government. And this is an opportunity for you to ask those questions. There have been several questions. Social media has been rife with a lot of complaints and saying, you know what, this isn't working, the other is not working. Well, Waziri is here and he's happy to take those questions for me. Let me remind you what that number is 0719-012-600, 0719-012-600. Those issues that you've had, those complaints that you've had, let's talk about it this morning and get answers to some of those things and where you can go to get those sorted out. All right, I'm going to remind you that the first ever Study Abroad conference took place on the 18th of January in Nairobi at the Gallant Mall in Parklands. Another one is taking place on the 27th at Eka Hotel in Eldoret. What can you expect when you go? You can expect that you will have access to the top professionals that will be able to match you with your needs to be able to study abroad from 600 destinations in 45 different countries. You have an opportunity to be able to look into what some of those will be. So there'll be a battle of the destinations. There'll be somebody who will talk you through how to get your student visa, information on accommodation, information on scholarships, whatever you think about when it comes to university education, the answers will be right there for you at the Eka Hotel on the 27th of January. How do you register? Go on to www.cradel.com or call 0799 000 444. All right. We know what the proverb is for today, but let's remind ourselves about that because Waziri believes that what you have inside will spur you on to go. No?
Yes. You can outdistance that which is running after you, but not what is running inside you.
But not what is running inside you.
Yes, if it's running outside and running beside you and behind you, and that you cannot pace it. But if it's inside you, no.
Tough luck.
That will not be possible.
All right. Okay, so we continue looking at some of these issues, some questions to do, with SHA and the system, and whether it is working for Kenyans to the point where they're saying, okay, well, this is actually worth our dime. A question. Go ahead.
Yeah, and when we talk about matters to do with SHA and shift that does exist now, we talk about the real cases that we have. Let me just read. I was at the hospital, but I couldn't get services because the system was down. I fear that if the situation persists, this woman's condition, the child's condition will continue to worsen. Now, these are at Longisa AGC Tenwek Mission Hospitals. Hundreds of patients were left stranded and frustrated.
Longisa?
And Tenwek. Now, this is another case of some medical facilities in Mombasa are accused of denying services to locals registered under the SHA scheme, leading to congestion in public hospitals. We will sit here and say SHA is working. But to that Kenyan who's seeking services right now, who has been denied opportunity to seek services, SHA is not working to them. There are teething problems, as you say, that need to be addressed. But how do we tell Kenyans who are seeking services right now and they're being asked to go back and tell them that SHA is working?
I'll tell you for sure, nobody is being turned away. I would be very much interested. And I'm willing to publish my number even publicly. I'm willing to publish my number. Because I know for a fact right now, maybe in the beginning, in October, in November, people are being turned away. Right now, and I'm challenging people to use the same channels and to reach me on that channel, or anyone for that matter, or CS for Health. Right now, at least on the very minimum from public hospitals, because at least those ones are within our control, nobody is being turned away. Nobody. From the private hospitals, maybe not. I would be very much interested to know. But what I'm saying, all I can see from where I am, in all fairness, is that as a matter of policy, and as a matter of what we know, as a matter of what is within our knowledge, what has been brought to our attention, nobody is being turned away. I would be very much interested to know about, first of all, Tenwek Hospital is one of the hospitals where we have actually done some level of digitization. And the president was there some times back, some few weeks back, in that particular hospital, which I know very well. And I know also of Longeza Hospital very well. I would be very much interested to know when exactly the system was down. I would be very much interested to know. I'm not saying the system could not be down. The system can get down. every system, even in a system, even Twitter sometimes can get done.
Yeah,
but I would be very much interested to know. All I'm saying is that I don't know what I can say from where I sit. All I can say is that where we are now, I am very much confident that the problems of system downtimes, the system of problems of availability, the problems of slow people getting OTPs when they are registering, or problems we encountered in October, in November, from December, and where we are now, I can only say, and I'm willing to to Kenyans sometimes walikuwa wananisalimia wakati wa Gen Z. If they can salimia me now with accurate details of exactly I went to this hospital, I was turned back, I would be very, very much interested to know. It's also for our benefit.
If there are problems, as we're being told, and they've been there since we rolled out this particular system, has the ministry taken the time to collate the issues that keep coming up so that we can say these are the frequently noted problems, these are the frequently asked questions, these are the frequently experienced difficulties, so that a response to those issues can actually also be provided?
You've provoked me. You've provoked me because from today I'll also create a WhatsApp group for media people. Put it there. Yeah. Put it there. I'll create one. I'll start with the three of you. And I'll also add people, all the media people from the other newsrooms. Yeah? So because first of all, you know me, forget about being a government official. I'm a professional project manager of 3 decades. This is what I do. I used to do for a living. I manage systems, I implement systems, I manage projects, I manage complex projects, I have managed them locally, I've managed them internationally. So I'm not just speaking, I don't know, from a political angle, from a leadership angle, from a government angle. I'm looking at this just like any other system I've implemented for banks and all that kind of thing. And I'm very poor with generalities. I am extremely poor, let me admit, on generalities. But when it comes to specifics, you tell me this particular case, this particular patient, this particular hospital, this particular hour. I don't sleep.
You see why I mentioned what I've just mentioned is because with all these health facilities, given the burden that a new system will bring with it, and given the toll of that on the people who work there, if over time you understand that when people come in, because you may think it's a systems problem, but it is a problem that is being encountered by the patient who has actually come in, because this system is, if it's new to those in the health facility, it is also new to the care.
Agreed. And those things, they go down, down as
over time,
as people get to understand, as doctors get to understand. And what I'm saying is to accelerate that going down of the uncomfortableness is let's go specific.
Yes, we can. And that brings me.
I wish now I was hoping that my extra time here, we open the line and someone tells me, I went to this hospital and this one. So that I can right here call somebody in the system to check for me what this particular case is.
I could actually take that challenge.
We're going to open the lines in just a minute.
Just open the lines and let's get specific. I went to this hospital, I was denied, I was told, if there's an answer, I'll give you the answer. If it is something wrong, I'll admit this is wrong. But ultimately, we have to build this together, me and you Kenyans.
All right, some of them from you.
I could actually take that challenge, I would not say their number, but we would take their ID number. And we find out, you make your calls, then we will give them feedback live here, because Yustofa Dachi says, since you've mentioned we give you your ID, could you please check for me what happened to my NHIF contribution? I'll give you their number. You find out what happened, just so we see how efficient that system is.
So in fact, what you could do is that once you give me their number, mobile number, I'll get somebody from SHA to call them, and they give us feedback.
Okay. Yustofa Dachi.
And let me say the generic policy on the NHIF contribution. Or there was portability of all NHIF contribution up to the point they were expiring in NHIF. So if you had 5,000 shillings paid until X amount, until that is exhausted, there was no money to be lost on NHIF.
Okay.
As a general rule. I would want to have the number of that guy. He's going to be called by somebody from SHA. There's a lady called Hazel Koitaba. She's going to call that person, and I would be very much interested to know, about that particular case. And that's a patriotic Kenyan who is helping me to fix the system. That's what I mean.
Another question that I would ask you, Mheshimiwa, is today with SHA being there offering universal health care, and you said if we could go back to your earlier opening statement that the 41 days that you spent in hospital and about 4 months in the hospital ward as well goes to show and the services that you are seeking outside the country today with SHA being in place and the 27,000 shillings that you have been contributing and deducted. Today, Moses Kuria, would you seek health services from Kenyatta National Hospital under SHA?
When we are done with this, when we get more money, when we get all those other 16 million people paying, so that you can even add the ICU, yeah? When you can add the HDU, when you can add the benefit, it will be possible. Not just for me, but for every Kenyan, yeah? Not just for me, but for every Kenyan, yeah? Yeah, so let's get everybody together. You know, I'm just saying this also, the fact that 2.7 million people paying for 54 million people. You know, we are heading dangerously to some cliff, which I think something has to be done. And because we've said it's a harambe for everyone, please, when we start saying everybody has to pay Atakamani 500, watch out to Sisiki again. It is media which is now again telling Kenyans munafinywa. We've said that this one was kama ni kufinywa, already the payslip people are being finywa. I feel for them. Me being one of them. I feel for the payslip people. They are paying for the NSSF contribution have gone up. Yeah, we have rated the same payslip. Is there something bad? No, because we can't continue as a country which does not have a savings culture. The same payslip we rated for the housing levy. The same payslip now we are rating for SHA. Now it's about time for the other people. And most of those people, they have more money than me and you.
Okay.
The people in the informal sector, they have more money than me and you. It is time for all of us now, media, everybody, to say, when we ask for a meal, everybody will eat. But when it comes to pay, let also everybody, open up their wallet and pay, so that everybody can be able to go to Kenyatta in the same way I would go to a foreign hospital.
What's the amount of money that somebody pays as a premium for SHA today?
Payslip or non-payslip?
Non-payslip.
Non-payslip. It's according to their means. You do some means testing. There's an algorithm there. And then it returns a value and tells you this amount you're supposed to pay every month or every year.
So I have to go into the system and see
as
now.
Register.
As I register,
yeah.
I get onto the system and it tells me based on the information that I put into it,
you should
telling
pay
me that per month 5, I will pay 5,000 or I pay 1,000
or 500
or something like that.
400.
So it gives me
or it tells you are completely indigent. What you call indigent, that government or somebody has to pay for you.
Yeah.
That also is possible. And counties are stepping up. Murang'a County, as we speak, has given us a check for 37,000 citizens of Murang'a who are indigent. Who are indigent after they have done the means testing. And the Governor Kangata has written a check for to cover that 7,000 according to the means, because we have to help each other. Governor of Mombasa, right now, since we started this exercise in Mombasa, now I've just received figures. Mombasa, in terms of percentage, Mombasa is now number 2 nationally, just down from Kirinyaga at 27.something%. And Governor of Mombasa is sending out these community health promoters door to door. And today we are starting even another exercise where we're going even to the schools and calling the parents there so they can register even their children and dependents there, so that ultimately people start paying. And the Governor of Mombasa and members of parliament, I've met all of them. We have agreed that MP will go back to the CDF, governor will go back to his kitty and look at these indigents and pay for them. Now, another interesting thing, even for the other people who are not indigents, we are talking to the banks to do something called insurance premium financing, whereby some of them are, even some of our telcos, like Safari committees, have come up with programs to enable these Kenyans to pay even by the day.
So how
like
quickly?
For the border people.
Sure. So how quickly, let's say, I'm onto the system, and this is based off of a number of questions from people in terms of, because one of the big issues here with a lot of questions that we're seeing is the waiting time to be able to then get logged onto the system and start to access. Because sadly, but is the reality that people then go onto the system when there is a need for them to access medical care, right? And I know I need to go to hospital, right? And I know that I'm going to be covered by SHA, but I have not registered for whatever reason. Obviously, if I'm non-salaried, right? And and I now get onto the system. The algorithm does what algorithms do, and I now know that I need to pay 1,000 shillings per month in order for me to access this because of the information that I've put in. What is the lead time between now me getting this 1,000 shillings and let's say now by the special grace of God I have 12,000 bob, so I pay for a year up front, right? What is the lead time between now that payment and now me being able to walk and say I need to see a doctor?
That is a very good question because I think you are the unconscious brand ambassador for SHA for the new system.
So
because under NHIF, we are waiting for 3 months. Sometimes I think even more than 3 months. Under SHA, it's instantaneous. There and then. There's no waiting time. What a tremendous jump. What a tremendous jump that before you had to wait. Now, we have opened door for everybody. You register here, you get treated there. Now, in Mombasa, the 51 public hospitals in Mombasa, all of them, we have got a registration desk inside the hospital. And this week, the 320 private hospitals in Mombasa, we are rolling out even these CHPs to go and register you there. You get registered, you get service there, and then, what an improvement.
I believe it is. Most people who go to hospital don't go with complications that may necessarily require surgery or may require some intensive care.
Yeah.
They simply need to be attended to and they'll go back home. Now, how do we get the citizenry to understand what to do when they have an issue when it comes to receiving the services that they're supposed to once they have registered with this new system? Because that really seems to be, in my mind, the heart of the matter. Because we're saying there are problems and it equals system is not working. Okay, we've understood. At the same time, we do get reports of people who say, but the system is working. I know because I have done A, B, C, D. So, to balance this, I'm going back to a question I'd asked earlier about the frequently
Ask a question.
Yes, and the frequently reported issues. Now, how do we ensure that healthcare providers understand in detail how to respond to this? Because instead of people going to the social media to complain, you're complaining about a situation in a hospital of health facility where you are. That problem could have been solved right there and then. What happens so that somebody now has to complain outside? So the whole world knows
that's a very
media.
good question because that's a very, very good question which I've been asking myself. I have to be honest with you, that why is our doctor, why is that doctor there? Why is that clinic officer? Why is that nurse not being the first ambassador of education, the first teacher to train the people? And that is exactly what we are training now. We are engaging more and more with the professionals, with the practitioners, because this health is a very personal, emotive issue. It's not a community issue. It is you as a person. And two, health is very experiential. Yeah. Until you experience it yourself, until you go there yourself, it's not a story you can be told. It's not something that you can outsource to somebody else. So, I cannot get sick and I said, Mr. Muga to the hospital on my behalf. It cannot happen like that. It is experiential. So the minute we look at the touch points, and that is why this digitization of the facilities is very, very important. That's why I'm putting no stops to ensure that we digitize our facilities. You know what does digitization do? It provides evidence. Because right now we have got so many things there. Because people are writing on these scribbled small pieces of paper. So we have no evidence of who was told what.
Waziri, is it difficult to have a help desk? Help desk.
No, we have a national help desk. Yeah?
No.
Oh, sure.
At the health,
at the health
every health facility, so that they know if you have an issue that you have a problem with, that's where you go.
And by the way, SHA has got facilities in all the government has got a desk in all the facilities. They do. We do have.
So what then one can expect is that the problems that we keep hearing of will not just, they will keep reducing over time.
I like this guy, what he has done. He has gone to Mombasa to the facilities. Okay.
Yes.
Yeah? And that's what I'm saying. I think we need to do together as government and media to do. Because I was talking to a friend of mine called Nicholas over Christmas. And he's part of the team that is delivering this. So he was going to Vihiga, to his home county, in a place called Shamahoho. So we were talking when he was driving on the way. So we agreed that he's going to stop everywhere along the way from Nairobi to Shamakoko and see how start to get some actual feel. Me, I'm a ground person. I'm a ground person. I like to listen to the ground. So he told me something funny. He told me whether it is something scientific because the amount of noise is inversely proportional to the distance from Nairobi.
The further you are from Nairobi,
the more people appreciate the system. You know, it shocked me, you know. I'm in the village. My mother is saying, oh my God, I've been... The other day we went to the governor to Coast General Hospital. Somebody who has paid 7,000 shillings had a bill of 1.2 million paid for. 1.2 million. 1.2 million paid for there. So, even what we are calling complaints, really, and that's why I didn't want to have this system of actual verification. The people, when they are experiencing, the real beneficiary, the people who are interacting with the system, especially our people within the rural areas, I don't know, they do tend to appreciate the system. And I think right now, social media is a very good thing. There's a lot of these conversations happening on social media. We just want this now noise to be backed up by actual specific evidence.
So you're saying that there's a danger now, for example, that folks may be joining a particular bandwagon and saying SHA is not working, even if it is. Is that what you're saying?
For those people who can afford, they are telling people who cannot afford normal health care that SHA is not working. You know, and I will say this for my own region where I come from, Mount Kenya region. When I was doing this outreach in the communities, and you know, right now there's a lot of negative politics within that particular region. So I told them, even if you are saying Ruto must go, join SHA so you'll be healthy. You live long to say Ruto must go. Because if you die, you not even be there to see Ruto go. You know, there's a lot of politics mixed up with this whole thing.
On the same argument, Waziri, of what benefit would it be for somebody to say a health system is not working when it is?
It is.
Why would I say that something that I go to a medical...
Ask me.
No, seriously, Waziri. Why would I Why would I walk into a medical facility?
Not you.
And if anybody, for example,
not you, not that anybody.
And
it's not the actual patient.
Got
the problem is somebody else saying.
Okay, so so what are you saying here is that
somebody discouraging people.
And these are not real people.
A patient who cannot afford.
And these are not real people who complain about the fact that
some people are between two categories.
Their grandmother of 80-something years old tried to register on the system and it wasn't working.
80-year-old mother would complain genuinely.
Yes.
I was in Mombasa and there was this lady. She told me she was 83. I have that recording. I can even send you that recording. She said, this system of yours, of star 147, how do you expect me as a grandmother with something to know how to interact with the system? And we told her, this is exactly why we are sending there. Now we have got a new way. We are sending the community health promoters inside the homes so that they can be able to, because we have to be realistic of the country that we live in. We cannot be pretentious about it, you know. Still, some people cannot, be able to use star 147 # to be able to register. So it is something genuine. And some people will complain genuine because either they are not well equipped to be able to access the service, and that's why I'm now going through that other loop of helping them where they are, recognizing who they are. It is not a crime not to be able to use a mobile device.
Or to even have one.
Okay.
Yeah? Or even not have one.
Right. Okay.
That's why we're now going now the other loop to send people to help even those people who need some assistance. So there's those genuine cases of either people are not equipped, people are not trained, people are not being communicated to, or maybe sometimes system gets lapses here and there. But then I'm also talking about this other cadre of people who discourage genuine people from using the system, them they can be able to afford, healthcare by other means. I think that is.
Let's take a question before we go to the break.
Yeah. You've just mentioned that there's someone who had paid 7,000, but the bill was 1.2, and SHA paid for that.
Yes.
But I want to take you to another question that has just been asked here by one of our listeners who says there is someone whose wife's bill was 370,000 shillings. SHA ikalipa 120,000 shillings. The balance is 250. The question now is, what is the criteria under SHA when it comes to settling these medical bills?
First of all, and maybe this is why I need also to to build that WhatsApp group with the media people, because you play a very important role in interaction with the users, so that I can be able to share with you the tariff. The tariff is published. You can find it in the website of SHA, of Ministry of Health. The tariff is a public thing. It was published in the Kenya Gazette. It tells you what is possible and what is possible. And I don't really want to ask Kenyans again and again, especially in the media, because we're interacting, to go through this tariff to see. When I tell you 3,940 for ICU, so then you know that is ICU. When I say what you are paying for surgery, what you are paying for maternity, and for all these things, then you're able to verify there. This particular case, I cannot answer, because maybe it's an ICU case, maybe it's a HDU case. Is it a general ward case? Is it an inpatient? What is it? There are so many other things there which the details can only be found within, one, what is the clinical case, and two, what is the evidence. Number two, that particular hospital, once we digitize that particular hospital, you'll be able to see, to answer that question even yourself, because I'll be able to say, I came on this date, I registered, I went to nurse X, she took 3 minutes with me, took me to a doctor, took me 7 minutes, I was referred to the lab, it took me 4 minutes, these are my lab results. I then went to the pharmacy for the drugs that have been prescribed for me. So that whole trail is going to be shown. Right now, I'm sure that information, even for that patient, is between one scribbled piece of paper from one person to the other person, making it, even for me, I have to now make the call, and, I would want to have the details of that person. But even from where it is now, I can't tell, because there are so many other parameters there. For example, what I suspect for that patient, you said they had to pay how many?
370,000.
And they were paid for
120,000.
120,000. I think that is somebody who was in ICU or HDU for like 30 days.
But you say
most likely.
You see Moses.
Because that gap there of what we paid and what the patient was charged, and I'm making just an intelligent guess, because I need to delve into this case, and I will delve into this case. That gap there of that funding is what I'm calling the emergency and chronic care fund, which really badly needs to be funded, and that's a gap we're having. But for general things, if somebody went for a general illness, even an inpatient in a level 2, in a level 3, in a level 4, hakuna kitu kama hiyo.
Waziri, the discussion that we're having has to continue for a simple reason.
Yes.
We have examples of people who are in that system and have had bills paid.
Yes.
In that same breath, we have people who keep saying they have these problems that keep coming up. Now, the categorization, which is represented by what we've just said, there is a lot about this system that is actually not understood.
Correct. And I think, City, I think you summarized that issue very well.
Yes.
Okay.
You summarized very well, because you said, why would it have to come to Moses Kuria or to Spice FM when there is a doctor, a facility there which can be able to
answer the question,
which can be able to handle that issue on the first line?
Yes.
I think that, for me, that's a profound point. That you've taken.
I have a friend who died at Coast General Hospital.
Sorry for that.
It was a person living with disabilities. Okay. All that he paid was 6,000 shillings because he had an arrears of what was supposed to be paid. When he was unwell, that was paid. His bill came to 260,000. It was paid.
Yes.
All of it,
yes,
was paid. So I know for a fact that from the example of my friend, SHA works. But there are many other hiccups. Now, unfortunately, these hiccups dominate the conversation. And so one gets the impression that this entire system is not working. And yet you keep hearing stories of people who tell you it is working because it has worked for them.
Yeah, absolutely. I think for me, first of all, health is largely a default function. And this is a conversation I'm going to have with the governors. About the first line of patient support. The first line of patient support cannot be SHA head office, because in any case, first of all, this is a devolved function. our primary relationship should be with the counties
with the county
and the hospital.
We do have some questions.
And by the way, something amazing we are doing in Mombasa. You know, national level, we have got another parastatal that was created called the Digital Health Authority,
right,
which is owning all the systems and providing the support. The governor of Mombasa has done some unprecedented thing. We are devolving that Digital Health Authority. Within the Department of Health of County of Mombasa, we are setting up a Digital Health Authority there, so that issues can be with the whole county, can have somewhere they are doing it. So again, when I say it is still work in progress, because the minute for 7 counties, and maybe this is a profound pointer that I'm taking from City from this interview. Maybe that's something that we first of all roll out. Irrespective of the system rolled out in all the counties, so that at least counties, we have some teams within every county, because it is time for governance. It's time for counties to take ownership of health.
Let's take some questions that are coming in.
Health is a devolved function.
Of course. Let's take some questions that are coming in. You can answer these directly. We'll hear first of all from Zachary in Kakamega. Zachary, good morning.
Good morning. How are you?
Very well, thank you. How are you doing?
I'm very fine. Good morning, Honorable Kuria.
Okay.
Yes, my question, I will break it down from the issue of the means testing. I am not sure whether Honorable Kuria is sure that we have the relevant data to operationalize the means testing instrument. And then 2, about the system. Previously, we had an SHA, and we patients never had issues to all systems. So I don't think they should be reducing us to the issue of discussing systems. We should pay up, go to a facility, get treated. The stories about system not working, that should be an issue to be sorted by the government and SHA. And about my experience, last year I was admitted, and for the first time, I was told to pay for the bed. I am fully paid up, member of I can call it NHIF, but I registered on SHA. So I think Honorable Kuria and the people implementing that system should acknowledge that even though they imagine the system is working, there are challenges. Let them not rubbish our complaints. There are challenges, we are going through them. They are likely to happen, but we need them sorted out and remove us from the issue of discussing systems. We need services. Thank you, and that's it.
Thank you very much for those questions. In terms of what the complaint was, in terms of now saying, if there's a system problem, folks are saying that should not be their problem. They should come in and be able to get services. Yes?
What is the actual complaint?
Well,
what he said was the complaint.
I've got the governor of Mombasa here. He's asking what's the number he can call, because he also wants to give his feedback.
The number is 0719012600. We'll take another call and take a quick break and come back. Waziri Moses Kuria is in the studio and he's taking questions from you. We'll take another call. Hello, good morning.
Good morning.
Yes, you have a question for Waziri this morning on SHA, Shif?
Actually, I just have to correct Waziri for a bit. The level 2 hospital that he is talking about do not have anything. You can go there, you are just given Panadol, no even testing. They don't have any facility. So when you use this system called SHA, payment is correct. You are paying and it accepts immediately. The problem is now to get the services. That is where there is a problem. So the Waziri should come to the ground and help us to access the system. Today, you cannot access the services without paying. Like for me, I'm paying 850. But before paying the amount, I cannot access the system, the services. So paying the hospital so that the hospital can get drugs and facilities squarely lie with the government. So let the government do their part so that the citizen can access the services. If I go to hospital and get good services, there is no day I'll complain about the services. That is the only thing that we are requesting.
Okay, so maybe now Waziri can get to that before we take a couple more questions, isn't it?
I think that gentleman is right. The owners will be on facilities. It will be on counties, and that one they cannot do back passing. They cannot pass the back. And once we are done with what we are doing in the next few months that we are doing this, I think counties need to start preparing on how to handle this, because they will have now there will be no national government to blame. It will be squarely on them. And Monanchi will be asked, you've been receiving money from this facility improvement fund. How much of my facility have you improved? So two things will happen. There are people who will be very unhappy with them. Yeah? And I'm saying this to all counties. Or two, those patients will migrate to private hospitals, because private hospitals, that gentleman, if he goes to a private hospital, he will be treated in exactly the same way as a public hospital. So right now, it's okay, everything is on the national government, but as soon as we are done with what we are doing and we finish this particular rollout and ensure the system is working, now the focus, I cannot speak for county government. I am saying it is up to every county government to smell the coffee.
And it shouldn't be under the same umbrella, since SHA right now, we know that health is devolved. However, there's an element of control that still comes from central government in SHA.
In terms of?
I mean, what are we talking about now? The system.
No, I'm saying once we're done with that bit, once we're done with the project, that's why I want, for 31st of January, national government to be out of all hospitals. Yeah, I want them out. So that now we say, look, don't come to me now anymore. Look for your governor. Yeah, because I've done what I need to do. Yeah, so I think, and this is something that we want to talk to governors, and we'll continue having this conversation with Council of Governors and all governors to say, let everybody do their part. I am liable for what is for national government.
Okay.
But again, the patient is right. Even in that case, they will not care whether it is national government or county government.
Not their
but
problem.
ultimately, somebody has to take accountability. Yeah.
Okay.
Remember, some of the facilities are also faith-based, and I'm saying this to our faith-based organizations. Even you now, we need to work together. Private hospitals as well. This is not a situation whereby now somebody can say that mine is okay, the other one is want to blame. This is a situation whereby all of us have to work together. But in terms of that gentleman, in terms of level 2 hospitals, yes. And my assurance to him is that is exactly why SHA came.
Okay.
So we have got some money dedicated for that particular facility.
Let's take some more questions, shall we? Hello, good morning.
Morning.
Good morning. Tell us your name and where you're calling from, please.
My name is Dr. Kimani. I'm calling from Ulaya.
What's your question for Waziri this morning?
I wanted to inform the Honorable Courier that SHA still does not have dental program. Previously, when SHA ilikuwa inalipia watu kung'olewa meno, tena saizi imewachilia watu.
Okay.
I agreed.
Solution.
Dental. More money.
Yes.
More money.
More money is needed from more Kenyans.
More money is needed for more Kenyans to be able to put this national harambee. Hii harambee hata kama ni ile, unajua kwa harambee kuna ile pesa tunasema you don't announce the money. Unasema na ingine mingi na mingi, hata kama ni hiyo kidogo. Hata kama ni ile haitangazwi. Let all of us, dental needs to be covered.
So as more money comes in, essentially
More
now
services.
what you are saying is that more
And that
services
is
will
why,
be offered and it will be announced that now dental is
that's why
available on the SHA.
Dr. Patrick Amod, our Director General for Health, this week is setting up a committee to review the benefit, because we will review the benefit commensurate with the money that is coming.
Okay.
This is our Harambe. It is
All
for
right.
all of us.
More questions coming in. Hello, good morning.
Good morning.
Hello, tell us your name and where you're calling from. Your question for Waziri.
My name is Jeanette, and I'm calling from upstate New York. As a Kenyan living overseas, when I watch this, it seems incredibly concerning that nobody is really explaining why the system is not digitized. It seems like part of it is, to say the least, slightly disorganized. And I don't understand how you can roll out a program without actually implementing systems and testing them before rolling them out. Thank you.
All right, thank you for that, Jeanette.
The system as disorganized as Obamacare. That it is in New York.
She's Kenyan.
Yes, 10 years later, I benchmark with the US and the UK. In the US, despite all the years of Obamacare, because it's still Obamacare that is at work in the US, there's still a lot of disorganization. There's no country with more, all those years, forget about us with the 110 days.
Excuse me. I'm not attacking you. I respect you. I respect your office. And I think that it's peculiar that we're not able to come together with all the people who are so gifted and so intelligent and create a system that actually works.
And what I'm telling you, my sister, is that the system we are creating within the next few months is going to be much, much more superior than the US system.
But why is it that you create a system that's not working?
How is it that the US
and
created
you
a
had
system?
one that was working.
How is it that you are accusing us of disorganization within 110 days?
Why are you being
America has had a system that is still leaking, that is still having a lot of complaints a whole 12 years down the line? Because these systems are works in progress.
Listen.
And it's not easy to have a system that is for the whole country, all 54 million people. I know to many people this is not something that should be done by a developing country like Kenya. But I'm a very proud Kenyan that even within our means and within our economic status, we are able to roll out a system.
So let's Jeanette, can we hear, if you do, it's a question that you have that we can get an answer for, and then we can move.
Oh, thank you. I appreciate that. I think the question would be, why isn't there a call center for people to call? Instead of running from one place to the next, complaint here, complaint there, like, pull it together, make it easy for people to get support, and just get the show on the road. It's just like we're just going round in circles.
Okay, so there's a question.
Thank you very much.
Thank you very much for that, Jeanette. Maybe we can get an answer for that in terms of one central place where folks can ask questions and then they can get answers for us.
I think we have got our national call center at SHA. Admittedly, we need to do more of public communication for people to know that this is where I call. Ultimately, I don't believe that is a solution because I'll go back to City Mbuga's position that most of these issues need to be handled at the lower levels, at the facilities levels. Put in counties as a layer also of, because health being a devolved function, that counties need to also set up their response centers, down there, and we are piloting that with the county of Mombasa. So let me say this: that I see four major issues that need to be tackled. One, of course, is counties have to improve facilities. That is what is really coming out. Second thing is that technology has to work, and that is what I am very comfortable with because that is directly within, my control as national government, what you can be able to do. The other one is clinical. I mean, doctors have to use a system in the right way to give the best treatment to people. But ultimately, it is on issue management.
Okay.
And that is where I think we have a problem, that we need to put in layers that are able to for people to know where they need to go to when they have a problem. And so this is also for the benefit of everybody, all the stakeholders, because once you have got a response, why I'm confident and why I appear like I'm not taking these issues is because at least I know what is happening.
Okay.
I wouldn't say that everybody else would know what is happening. So ultimately, when people know where they need to complain, then I think
it makes it easier.
We are able to separate the real issues from the presumed issues.
Let's take a few more calls as we can.
Overall, 110 days. Now in the national health system of the UK, in the National Health Service, NHS, we have got waiting queues of up to 4 months. I dare say like our M-Pesa. And I was here when we started.
Yeah.
And I said from M-Pesa, the next big record, Kenya is going to keep us on this SHA.
Okay, let's take a few more questions. I think it's important that we hear from folks. Hello, good morning. Can you tell us where you're calling from and your name? Hello, good morning. Hello? Okay. All right, let's take some more of those calls. It's 0719012600. Some of those dropped off as we wait to hear back from you. So, I mean, here, and I think these are some of the things that you've just given kind of like a recap to, Waziri. So, some of those calls coming back, 0719012600. Looking at SHA and how it can actually work. One of the big ticket items is that centralized call. Dennis, there were some questions coming from you.
Yeah, there are questions that are coming from those who are watching us on YouTube, and one of the key areas that have been asked is before the rollout of SHA, was there a pilot program to make sure that all these teething problems have been addressed? Because there is a feeling that even at the point that we were launching it, we did not sit back to roll it out and look at the teething problems that we're now dealing with.
By the way, I was there on the 1st of October. It was chaos. It was chaos. 1st of November, less chaos. 1st of December, much less chaos. Today, specific isolated cases here and there. You know, I wonder what we'll be saying in July, for example. I wonder what we'll be saying in July and all that kind of thing. And that's how good it is. You know, this is not a small company. It's a Kenya of population of 54 million people. The county of Mombasa only, after we're done digitizing by that 1st of January, is the same population as Estonia. It's the same population as Bahrain. If you take their 1.2 million population, you rank it according to our population. I'm saying it's possible that the county of Mombasa will leapfrog over Estonia in terms of the number of people receiving medical services, healthcare digitally. If it was a country on its own, it would have a world record, the county of Mombasa. Now imagine now when we make this across to all the 47 counties. A country of 54 million people. I'm really watching this, and I want the next time you get your correspondents in the UK and they tell you the kind of chaos we have there. I think I know ideally, because I'm a systems person, I know it is possible, it is the right thing to do a pilot program, to do a pilot and something like that. But I'm telling you, that was not something that was not under our consideration.
Let's take another question. Tell us your name and where you're calling in from. Good morning.
Good morning.
Yes.
This is Murunga Masinde.
Yes.
I'm a retired teacher.
What's your question for Waziri this morning?
My question is, when you have retired, you don't get the pay slip. I don't know how much I'm contributing or I'm not contributing. How do I understand even if I've registered, how do I understand what I'm paying there? Or that's my problem. You have retired. You don't get a pay slip. You want to know what is being deducted or you are not being deducted for the SHA.
Okay. Hold that question, Waziri. Thank you much for your question. And let's take another one. Hello, good morning. Hello, good morning.
Good morning.
Good morning. Tell us your name and where you're calling in from and your question for Waziri.
My name is Boit. I'm calling from Nakuru. And kuna swali kwa Waziri. I'm Maoni. Mine is on the means testing, Waziri.
Yes.
When you go through the process, the means testing places you on a very expensive premium rate. Where can one go for review or appeal for this? Because it's a serious issue. Some of us are not insured because of that.
Okay.
That's a very good question.
It's a good question.
Let's go to the teacher
can we hold on to that one and take one more and then you can answer the three in one shot? Is that okay, Waziri?
Yeah.
All right. One more question. Hello, good morning. Could you tell us your name and where you're calling from?
My name is Biwot. I'm calling from Nairobi.
Yes, Biwot.
I would like maybe just to give a comment because I think the problem is not really SHA. The problem with this country is tenders. Why am I saying tenders? Because people would want to create an issue so that they create a tender to consume something. I leave that comment at that because Waziri understands. That's why you see people, those who are against the tender, saying so much about SHA, those who are pro-tender, defending it so much despite it not working properly.
All right.
So, like some of us who are in Juakali, no one is really telling you how to contribute, what benefits you're getting, how is it going to support my family and I. But every day we are being told it's working. It's working. But NHIF was working for me. I was in Juakali. It worked for many years. Then one day I was told it's no longer working. So you see, for me, they wrong-footed me.
All right. Thanks for those questions, Biwot, on that comment. Let's allow Waziri to...
Let's start with Biwot. You see, now that it's Biwot, now I need him to pay.
Okay.
Yeah, that your carry guy is the one who is making me pay myself alone. But Biwot is also raising a very pertinent issue that once he pays, I don't think Biwot has a problem paying. He also wants to know what are the benefits he is able to get. Retired teacher is now just like informal sector people. So he needs to go there in the system, do the means testing like anybody else, and the means testing will tell him. So this, as long as you are not on pay slip, the system does not know whether you are retired or where you are working or not. So it treats you just like any other person who is in the informal sector. So I want to ask Mr. Retired Teacher to go and do the means testing so that he can know what he contributes. The gentleman from Nakuru on the means testing complains the complaint system for means testing. We have got our SHA hotline, our SHA, and I think the takeout here is that we need to go out again and again and again, and you'll see us coming to media.
Yeah,
you'll see us coming to media now to say not about SHA is working or not working.
Yeah,
but to tell Kenyans if you have a problem, this is how you complain.
Okay.
Yeah?
Yeah.
It is a touch point of complaints that are admittedly an issue.
Okay.
Yeah? I think even from listening to Kenyans, nobody's saying SHA is not working. People are just saying, when I have something, either out of ignorance or out of genuine concern, I don't know where to go.
And I think that's why it's important to do this. And so I'm going to do something this morning uncharacteristically.
Yes.
Because we have too many questions, and we have you here, and we're going to ask for some 20 more minutes of your time after the top of the hour. I would like you to hear what Kenyans are asking and give them answers for them while they're here. Can we do that?
I was coming here for an hour.
You were coming here for breakfast. We're going to offer you lunch and dinner.
We make it like it's gonna be lunch here.
We don't know when we'll see you next, so let's take advantage when we have you, isn't
Those people who are asking questions are the ones who pay my salary.
There you go. All right. So we'll be with him for another half hour. Let your questions keep coming in after the top of the hour. Good morning. It's 9 a.m.